بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. The lecture is about inborn error of metabolism. In this lecture, we are going to talk about defect in amino acid metabolism. The lecture will be presented by Dali Ibrahim Waghallah, Assistant Professor of Clinical Chemistry. The first amino acid metabolism disorder we are going to talk about is phenylketonuria. Phynylketonuria is an inborn error of metabolism that results in decreased metabolism of amino acid phenylalanine. The enzyme phenylalanine hydroxylase normally converts the amino acid phenylalanine into amino acid tyrosine. It is a reaction. If this reaction does not take place, phenylalanine accumulation and tyrosine is deficient. This results in the build-up of dietary phenylalanine to potentially toxic level. It is an autosomal recessive, meaning that both copies of the gene must be muted for the condition to develop. There are two main types, classical phenylketonuria and variant phenylketonuria. Phenylketonuria lead to mental retardation, seizure, fair skin, mossy odor, and eczema. Diagnosis: phenylalanine hydroxylase deficiency can be diagnosed by newborn screening. A normal blood phenylalanine level is about 1 milligram per deciliter, and in phenylketonuria, blood phenylalanine is more than 6 to 10 milligram per deciliter, or 360 to 600 micromole per liter. Blood tyrosine is less than 3 milligram per deciliter. So to diagnose phenylketonuria, we have two things: either accumulation of phenylalanine, which is normally 1 milligram per deciliter. In cases of phenylketonuria, the level is increased more than 6 to 10 milligram per deciliter, which is corresponding to 360 to 600 micromole per liter, or either the deficiency of tyrosine, which its level is less than 3 milligram per deciliter. Phenylketonuria can be diagnosed either by accumulation of phenylalanine or deficiency of tyrosine. The normal metabolism of phenylalanine pathway A and B. When the phenylalanine come from the diet, the phenylalanine hydroxylase enzyme convert the phenylalanine to tyrosine. Also, phenylalanine can go to the protein body pool. The tyrosine is breakdown, and the circulation phenylalanine and tyrosine are normal. In case of the abnormal metabolism in phenylketonuria subject, here we can see it in the position C. The phenylalanine cannot be converted to tyrosine due to deficiency of the enzyme phenylalanine hydroxylase. So what is happening? Phenylalanine is converted to two metabolites, phenylactic acid or phenylacetic acid. These two substances are agents thought to be responsible for mental retardation. So we can repeat this for second time. In phenylketonuria, the enzyme phenylalanine hydroxylase is deficient. So phenylalanine cannot be converted to tyrosine. It converted to hydroxyphenyl lactic acid or phenylacetic acid. These two metabolites are agents thought to be responsible for maintenance retardation. So this is the cause or pathophysiology of phenylketonuria. Symptoms of phenylketonuria: about 50% of untreated infants have the following early symptoms. Infants with classical phenylketonuria appear normal until they are few months old. Without treatment with special low phenylalanine diet, these children develop permanent intellectual disability, seizure, delayed development, behavioral problem, and psychiatric disorder. Untreated individual may have a musty or mouse-like odor as a side effect of excess phenylalanine in the body. Children with classical phenylketonuria tend to have lighter skin and hair and are also likely to have skin disorders such as eczema, vomiting, irritability, unusual odor of urine, nervous system problem, increased muscle tone, more active muscle, tendon reflexes, microcephalus, decreased body growth, and prominent cheek and chew bone widely spaced teeth and poor development of tooth. Medical management: regular monitoring of blood phenylalanine to maintain at 1 to 6 milligram per deciliter. Nutritional assessment: assess parental and family support for important nutrition therapy. Nutrition care: phenylalanine free formula medical food, low phenylalanine food, supplement with tyrosine due to tyrosine deficiency. Education of family and child about formula medical food preparation, adequate nutritional intake, regular monitoring of growth, education on label reading and food choice. However, the current recommendation of most clinicians is to effective management of blood phenylalanine concentration through medical nutrition. So, as summary for phenylketonuria treatment, it is to avoid food containing phenylalanine and replace tyrosine. Tyrosinemia is the second disorder of amino acid metabolism. Tyrosine inborn error is in the degradation of tyrosine. People have problem break down amino acid tyrosine from the food they eat. Hereditary, autosomally recessive, has 3 types. Type 1, which is due to deficiency of enzyme fumarate acetoacetate hydrolase. Type 2, deficiency of the enzyme tyrosine aminotransferases. Type 3, deficiency of enzyme 4-hydroxyphenylpyruvate deoxygenase. Type 1, tyrosinemia 1 occurs when an enzyme called fumaryl acetoacetate is either missing or not working properly. There is a mutation in FAH gene that encoded for the FAH enzyme. When this enzyme is not working, it cannot break down tyrosine and other harmful substances then build up in the blood. Can be either chronic or acute. Acute present in infancy and chronic appear later in the life. Symptoms of type 1 tyrosinemia: failure to gain weight or grow, diarrhea, blood stool and vomiting, jaundice of skin and eye, cabbage-like odor to the skin or urine, increased tendency of bleed, extreme sleepiness, irritability, enlargement liver, yellowing of the skin, tendency to bleed, swelling of the legs and abdomen, liver cirrhosis, hepatocellular carcinoma, kidney problem, rickets, delay in working. Type 2 tyrosinemia caused by mutation in TAT gene that encoded for the hepatic liver TAT enzyme, also known as Rencher-Hanhart syndrome. TAT gene code for aminotransferase, tyrosine aminotransferase, which is responsible for converting tyrosine to 4-hydroxyphenylpyruvate. TAT is enzyme involved in the first of series of 5 reactions of tyrosine degradation occur in cytosol. Number 1, pyridoxal 5-phosphate depending enzyme transaminases tyrosine and alpha keto glutarate into pyridoxal into p-hydrophenylpyruvate and glutamate. Symptoms of type 2 tyrosinemia: elevated serum and plasma tyrosine level, lesion of the skin and eye due to clumping of cellular tyrosine crystal, excessive tearing, abnormal sensitivity to light, photophobia, lacrimation, burning eye pain, inflamed conjunctiva, microcephaly, mental retardation caused by elevated blood tyrosine level, blistering lesion on the palm and sole, delay, behavioral problem, and self-injurious behavior also occurring frequency. Symptoms often begin in early childhood. Type 3 tyrosinemia, deficiency of 4-hydroxyphenylpyruvate deoxygenase, caused by mutation or in the HBBD gene that encoded for second enzyme involved in tyrosine catabolism pathway, require ferrous, oxygen, and alpha keto acid substrate, typically alpha keto glutarate. Symptoms of type 3 tyrosinemia: mild mental retardation, seizure, loss of balance and coordination, intermittent ataxia, high blood and urine concentration of tyrosine, and HPV. Diagnosis: newborn screen, tandem mass spectrophotometry, maintaining tyrosine level below 800 micromole per liter appears to be protective against pathway including neurological sequence. Goal of dietary management: support an appropriate rate of growth, support normal intellectual development, maintain optimal nutritional state, provided adequate nourishment, prevent neurological crisis, prevent liver and renal function problem, prevent formation of tyrosine crystal in the eye. This occurs with elevated plasma tyrosine level. Nutritional treatment: the diet is made up of the foods that are very low in tyrosine and phenylalanine. M2 is below 500 micromole per liter, and it is made up of special medical formula. These are other medical foods such as special flour, pasta, and rice that are made especially for people with tyrosinemia 1. There is a need to limit foods such as cow milk, meat, egg, cheese, regular flour, dried beans, and nuts and peanuts butter. The other inborn error of metabolism is maple syrup urine disease. It is an autosomal recessive metabolic disorder affecting branched chain amino acid. It is one type of organic acidemia. The disease is named for the presence of sweet-smelling urine with an odor similar to the maple syrup. It is potentially deadly disorder that affects the way the body breaks down 3 amino acids, leucine, isoleucine, and valine, used as a supplement for body muscles building. People with maple syrup urine disease have mutations that result in deficiency for one of the 6 proteins that make up this complex. Therefore, they cannot break down leucine, isoleucine, and valine. They end up with dangerously high level of this amino acid in their blood, causing rapid degradation of the brain cell and death if left untreated. The mechanism of maple syrup urine disease is metabolic disorder caused by deficiency of branched chain alpha keto acid dehydrogenase complex, leading to buildup of the branched chain amino acid leucine, isoleucine, and valine, and their toxic byproduct keto acid in the blood and urine. As a result, the amino acid and their body product build up in the body. Because high level of this substance are toxic to the brain and other organ, this accumulation lead to the serious medical problem associated with maple syrup urine disease. So maple syrup disease is due to accumulation of the branched chain amino acid leucine, isoleucine, and valine due to the deficiency of the enzyme alpha keto acid dehydrogenase, which is responsible for degradation of this amino acid. This amino acid accumulation is lead to medical problem associated with maple syrup urine disease. Symptoms include there are several types of maple syrup urine disease. The most common classical form typically will produce symptoms in newborn infant aged from 4 to 7 days. These symptoms may include poor feeding, vomiting, poor weight gain, increasing lethargy, which is mean difficult to wake up, characteristic burn sugar smell to urine, change in muscle tone, muscle spasm, and seizure. Diagnosis: in some states, the babies are screened for maple syrup urine disease within 24 hours after birth. A blood sample taken from the baby heel is analyzed for high leucine level. If maple syrup urine disease is suspected based on the physical symptoms, especially the characteristic of urine odor, a blood test for amino acid can be done. Treatment involves dietary restriction of the amino acid leucine and isoleucine and valine. This treatment must be begun very early to prevent brain damage. Babies with this disease must eat a special formula that does not contain amino acid leucine or isoleucine and valine. As a person grows up to adulthood, he or she must always watch their diet, avoiding high protein such as meat, eggs, and nuts. The level of 3 amino acid still get too high. Patient can be treated with intravenous given through a vein solutions that help through the body use up excess leucine, isoleucine, and valine for protein synthesis. Gene therapy is also potential future treatment for patients with maple syrup disease. This would involve replacing the mutated gene with a good copy, allowing patient cells to generate functional block protein complex and break down excess amino acid. Homocystinuria or cystathionine beta synthase deficiency is an autosomal recessive inherited disorder of methionine metabolism. Methionine is an essential nonpolar alpha amino acid. Under normal condition, methionine undergoes conversion to homocysteine. This in turn undergoes trans-sulfuration to ultimately yield cysteine. This step is catalyzed by the enzyme cystathionine beta synthase (CBS). People suffering from this disease are unable to synthesize CBS, hence leading to an inability to metabolize methionine. Symptoms include homocystinuria is combined by a variety of clinical and pathological abnormalities which show major involvement in four organ system: the eye, skeletal muscle, central nervous system, and vascular system, ectopia, lentis, and high myopia, and are the major ocular manifestation of classical homocystinuria. The most striking change, however, is that of skeletal. One of the distinguished features of classical homocystinuria patient is the presence of osteoporosis, especially spinal osteoporosis. Another known symptoms of the homocystinuria is the thromboembolism affecting the both large and small arteries and veins. It is also the most striking cause of serious complication and mortality in this disease. Mental retardation is the most frequent central nervous system abnormality, and it is often the first recognizable sign of the homocystinuria. These patients show a wide variation in their IQ level with a median IQ of 64. Diagnosis: newborn are tested for homocystinuria before they leave the hospital. The test usually look for high level of methionine. If the test is positive, blood or urine test can be done to confirm the diagnosis. These tests can be detect high level of methionine, homocysteine, and other sulfur-containing amino acid tests to detect an enzyme deficiency such as cysteine synthase can be done as well. If a child not tested at birth, a doctor may later discover disorder based on symptoms. At that point, the following may be done: blood test to confirm the diagnosis, X-ray to look for bone problem, and eye exam to look for eye problem. Treatment: effective treatment require early diagnosis and initiation of therapy. Try pyridoxine in all methionine restricted, cysteine supplemented diet for those who do not respond to pyridoxine. Methionine restriction has been shown to prevent mental retardation and reduce the rate of lens dislocation and seizure activity. Pyridoxine supplementation for response usually 50% of the patient affected. The use of pyridoxine treatment can be effective late in reduce the rate of thromboembolic event, avoid folate deficiency. There is no cure for homocystinuria. However, many people respond to high doses of vitamin B6, also known as pyridoxine. Slightly less than half of patients respond to this treatment. Neither a low methionine diet nor medication will improve exciting mental retardation. Medication and diet should be closely supervised by physicians with experience training homocystinuria. So that is all about amino acid metabolism. Thank you for good listening and see you in the next lecture.